Good afternoon, everyone, and thank you for coming to this ENDRA Life Sciences AASLD session, where we will be discussing non-invasive diagnostic of NAFLD and current and future pharmacotherapy for NASH. Before we start, I'd like to remind everyone of what ENDRA does and what TAEUS is. So TAEUS is a proprietary tissue characterization platform technology that uses a very innovative and unique dual energy radiofrequency and ultrasound to assess tissue. Specifically, our first application is the assessment of NAFLD, non-alcoholic fatty liver disease. This is a point-of-care system. This is non-invasive. This is easy to use. And I encourage you all to come to booth 716 during the show that will open in a couple hours to get a live demonstration or ask any questions you may have about our technology. Without delay, I'd like to introduce our two speakers, Raza Malik, who is the Chief of the Division of Gastroenterology and Hepatology, as well as the Vice Chairman of the Department of Medicine for Research at Albany Medical Center in New York, who will be talking about non-invasive diagnostic for NAFLD, and Dr. Chris Kowdley, who is the director of the Liver Institute Northwest and professor of medicine at Washington State University in Seattle, Washington. Dr. Kowdley will be talking about current and future therapies, therapeutic for NASH. Dr. Malik, I'm going to leave you the floor. Thank you.
Thank you, Renaud, for that introduction and your exciting new biotechnology that's coming out in the area of non-invasive diagnostic testing in NAFLD. And as a follow-on to that, I'd just like to give an overview of this area, this disease state. As Renaud mentioned, my name's Raza Malik. I'm the Chief of Gastroenterology and Hepatology and Vice Chair of Medicine at Albany Medical Center and Albany Medical College. And firstly, you know, talking about being back at AASLD, it's just so nice to be in an intimate setting back after 2 years. And so, you know, first of all, thank you for everyone who's attending. We're having a great conference. It started already, and we're excited to learn from all friends, colleagues, and hepatologists throughout the next few days. Talking about the pathogenesis of non-alcoholic fatty liver disease and NASH, it's the combination of a Western lifestyle with a high alimentary diet, high-fat, high-sugar diet, combined with, in certain groups of patients, genetic predispositions, the most important one being the PNPLA3 genetic allele that increases your risk of insulin resistance, that then causes fat deposition, hepatic steatosis to develop in the liver as part of the metabolic syndrome. And the metabolic syndrome consists of abdominal obesity, hyperlipidemia, dyslipidemia, non-alcoholic fatty liver disease, type 2 diabetes, hypertension. And if we look at the obesity trends among the US adults, this is a lot of our listeners will be familiar with this data, but it's important for refreshment reasons to actually see this, is that, you know, there's been a significant increase in obesity trends among US adults from 1990 all the way into the 2000s, with an obesity epidemic, with 1/3 of the US population having both obesity and non-alcoholic fatty liver disease. And interestingly, there's about 3 to 5% of the US population has NASH, which is the more severe form of non-alcoholic fatty liver disease that I'll talk about in the next few slides. Globally, there's an estimated 1 billion people with non-alcoholic fatty liver disease. So it's not just a disease of the developed world, it's a disease of the developing world as well, and it's seen throughout Asia, the Middle East, and Africa as well. If we look at prediction models, we can say that we've known about this epidemic for 20 to 30 years in obesity and NASH. And sometimes you can do an epidemiological interventions that reverse those epidemics, and you can see improvements. And that's what you try to do from a public health standpoint. You try and have an intervention for obesity and for NAFLD, and you try and reduce its incidence and prevalence over a period of time to try and combat that from a public health standpoint. But if you look at the interventions that we've done over the last 2 decades in non-alcoholic fatty liver disease, there's still a significant disease burden, and there's going to be continued increase in the number of patients who are going to have non-alcoholic fatty liver disease, NASH, hepatic fibrosis, cirrhosis, liver failure, and liver cancer going into the next few decades. So this is a slide looking at a few different countries. The United States is leading in terms of obesity, BMI greater than 30, closely followed by Mexico and the United Kingdom. So 1/3 of the US population has obesity and non-alcoholic fatty liver disease. If you look at the natural history of non-alcoholic fatty liver disease, it normally starts with hepatic steatosis, simple fatty liver, non-alcoholic fatty liver are the different terms used for it. With the non-alcoholic fatty liver disease, approximately anywhere between 5 to 20% can progress to NASH, which is termed non-alcoholic steatohepatitis, where the fatty liver converts to necroinflammation and it increases your risk of cirrhosis, which then increases your risk of primary liver cancer, also known as primary hepatocellular carcinoma, and also liver failure as one of the causes of decompensations in cirrhosis. And if you look at some of the algorithms that you can use, you can start to profile patients, because it's important to determine which patients with non-alcoholic fatty liver disease are going to develop NASH. So you start on the right side of this panel to see that in the metabolic syndrome, if you have advanced age, if you have type 2 diabetes, if you have a BMI of greater than 40, if you have a high AST, ALT levels in the blood, if you have a high genetic risk with the PNPLA3 allele, you start to increase your risk of having NASH. And that's some of the profiles that I use in my patients in the clinic. If we look at the pathology, on the left side of the panel, you can see simple steatosis on non-alcoholic fatty liver. You can see large lipid droplets within the hepatocyte, hepatic steatosis, macrovesicular steatosis with the white lipid droplets within hepatocytes. And on the right side of that, you can see the NASH panel, in which there's small inflammatory cells, necroinflammation occurring with the steatohepatitis, characterized by apoptotic bodies, characterized by necroinflammation and ballooning degeneration within the hepatocytes. And it's that second hit where you get hepatic steatosis, then followed by necroinflammation that increases your risk of getting cirrhosis. If you can look at the panel with cirrhosis, that's collagen staining, and you can see that there's abnormal architecture with fibrotic nodules and increased collagen deposition within the liver. And that goes on to increasing your risk of liver failure and liver cancer. And the higher your NAFLD activity score in the liver, the higher your risk of developing cirrhosis and liver cancer. So this is a Kaplan-Meier curve that shows that basically a cirrhosis is associated with adverse outcomes, and so patients who progress with advanced fibrosis and cirrhosis have more negative outcomes in terms of their progression in their non-alcoholic fatty liver disease, and they're at higher risk of morbidity and mortality and death. I always take a reset with this in terms of recognizing that not only does the NASH have not only does the NASH cause increased risk of liver failure and liver cancer and death, but independently of NASH, having NAFLD in itself, independent of NASH, has and carries increased and significant risk of morbidity and mortality associated with the cardiovascular disease. And that's something that we all have to remember. It's not just about identifying NASH, it's about identifying the fatty liver, the increased cardiovascular morbidity and mortality associated with it, and that whole population needs to be treated. So in terms of looking at the diagnostic testing, liver biopsy is invasive. From a technical standpoint, there's inter-observer variability and sampling bias when you take a biopsy. It is our gold standard of care right now. And In terms of trying to find an alternative, we're looking for non-invasive markers as an alternative to an invasive biopsy. So there's different markers that you use. There's a variety of non-invasive tools that have been studied in terms of biochemical, lipidemic, metabolic, transcription, imaging, multiparametric imaging assessments, and these have all been used as composites or individually to try and find non-invasive ways of assessing, number one, non-alcoholic fatty liver disease, and in most cases, number two, identifying and risk stratifying those patients who will get NASH compared to those who have simple steatosis or non-alcoholic fatty liver. We originally, in our lab, looked at cytokeratin 18 as a marker to identify NASH, looking at the NASH CRN score of greater than 4 as our risk factor for NASH, and identifying a cutoff of cytokeratin 18 of 350 micromoles per litre as a non-invasive marker for NASH. And we got to an AUC of 0.75. And it's important to look at the different markers that have been used over the last decade or two. On this panel, you can see a number that have been used: the BARD score, the NAFLD fibrosis score, the age over platelet index, the AST to platelet ratio, and also the AST over ALT ratio and the FIB4 index. These have all been used as non-invasive markers to assess the severity of non-alcoholic fatty liver disease, to try and differentiate patients who are at increased risk of NASH, usually looking at fibrosis. And fibrosis on a liver biopsy is the gold standard. And in terms of the two tests that have come out in terms of top, we would say that FIB4, which is a composite of age, AST, ALT, and the platelet count, and also the NAFLD fibrosis score, which is a combination of age, AST, ALT, platelet count, BMI, albumin-impaired glucose. These are all important scores to help us in a non-invasive way of looking at fibrosis and NASH in patients with non-alcoholic fatty liver disease. It's important to say at this point that a lot of the serum markers have not reached their diagnostic accuracy thresholds for identifying NASH. We look for an AUC of 0.9 in diagnostic testing to meet a threshold, and in spite of that 0.9, the FIB4 and NAFLD fibrosis score in a lot of studies have not reached that threshold, and they're by far the best. So sometimes what we use is a low cutoff, and we use a high cutoff, so the low cutoff being the negative predicted value cutoff, and the high cutoff being the positive predicted value cutoff, and we use a range of which we can exclude people who we don't think have the condition, and you use the high cutoff PPV to include people who do have the condition. So we start to use and create a range to identify patients in terms of non-invasive assessment. This was a study that we did looking at fibrosis and cirrhosis, where we looked in this panel, you'll be looking at the non-hepatitis C population as the population of patients with NASH, because they formed a significant number of those population of patients with non-hepatitis C. And you look again at the AU-ROC, the area under the receiver operator curve, and again, you know, the clinical, none of the markers in this, we used imaging with FibroScan greater than 12, we used hyaluronic acid, APRI score, AST over ALT ratio, and clinical signs, and we were finding that none of the markers were reaching our 0.9 threshold, but they were starting to get there. There was some, you know, momentum that we were approaching that 0.9 threshold for diagnostic accuracy for a non-invasive marker. So this was in terms of different imaging that's used as a non-invasive tool to assess non-alcoholic fatty liver disease. We've looked at different types of imaging, including transient elastography with CAP measurement as a measuring tool for NAFLD. We've also looked at new technology. The MRI-PDFF correlates with, you know, the severity of the steatosis. This is by far probably the best imaging tool that's used in terms of non-alcoholic fatty liver disease, but it involves MRI technology. And if we look at the different comparisons of looking at imaging tests, and we also look at biomarkers and serum markers, we start to determine that imaging tests are probably getting there, especially with MRI-PDFF as being more accurate than laboratory-based tests. And now there's a trend towards having a combination of using one serum marker and one imaging test and combining the two to increase your diagnostic accuracy as a non-invasive marker in non-alcoholic fatty liver disease, especially to identify and differentiate between NASH and non-alcoholic fatty liver or simple steatosis. So in terms of what we do in our clinic, we have a multidisciplinary approach to the treatment of a NAFLD patient. As I mentioned earlier, obesity is a very important component, and so we have an endocrinologist, we have a bariatric surgeon, we have a clinical trial specialist because we don't have any current significant therapeutics in NASH, so we're trialing a lot of the different therapeutics that are in trials, and Dr. Kowdley is going to give us an update on the therapeutics in NASH in a few minutes. We have a hepatologist, we have a nutritionist and a psychologist. So we have a variety of different multidisciplinary team members, and this is the area that I'd really like to home in on in these patients. I want to find out what's happening in terms of their fat, their steatosis in the liver. You can see the panel at the lower side of the screen are patients who've had a bariatric surgery or low caloric diet, and you can see over time that the fat in the liver on MRI-PDFF is going down, and you're quantifying it, and that's what you want to see as a clinician, is to see that improvement in the liver to reduce your risk of hepatic steatosis, to reduce the risk of cirrhosis, future liver failure and liver cancer. So in terms of conclusion, I would say that there's an unmet need to develop non-invasive tests in NAFLD to assess the disease severity. I've described that liver biopsy is invasive. It carries undesirable risks with it. Imaging tests are showing utility and greater accuracy as non-invasive markers. And these non-invasive markers are providing an alternative to liver biopsy to stage and grade non-alcoholic fatty liver disease. Currently, the standard of care is to look at a FIB-4 or a NAFLD fibrosis score as your serum test and combine that with the MRI-PDFF as the best current tools that we have available to assess non-invasively the severity of non-alcoholic fatty liver disease. And, you know, in terms of MRI-PDFF and in terms of the NAFLD fibrosis score, there's a reduced, AUC with the fibrosis score. MRI-PDFF is expensive. There's resources availability challenging with MRI-PDFF. So there is an unmet need for a serum marker with a high efficacy, with AUC above 0.9. To quantify fat in the future. And this really reflects what I'm talking about in terms of what you're looking for. Is you're looking for an accessible test that's affordable and safe to use, and one that has a high diagnostic value. So you can see that liver biopsy and MRI have a high diagnostic value, but in terms of accessibility, because of the risks of biopsy and the resources related to MRI-PDFF and access to it, that they're reduced, and quantitative ultrasound, traditional ultrasound, FibroScan, blood tests, they have high accessibility, but they have a lower diagnostic value. So we're looking for one that has both a high diagnostic value and high accessibility. And so these are really, really important things to do in the future, because as we're looking at clinical trials in NASH and new therapeutics coming into the area of non-alcoholic fatty liver disease, we need to have tools independent of liver biopsy that can assess the response to therapeutics, so that we can stage individuals' response to treatments, whether it be surgical treatments in bariatric surgery or whether it be in clinical trials with the multiple agents that are going through clinical phases at the moment in therapeutics and NASH, to be able to monitor the disease and to monitor disease progression. And on that note, I'll complete the talk. Thank you. And if there's anyone who's got any questions, please feel free to ask. It gives me great pleasure to introduce Chris Kowdley, who's the Director of the Liver Institute Northwest and Professor of Medicine at Washington State University. Chris is both a regional and national figure in liver disease, and I'd like to welcome him now.
Thank you, Raza. I appreciate the opportunity to give this talk on current and new pharmacotherapies, and would like to thank Kendra for giving me the opportunity to present. So you heard a very nice background from Dr. Malik about the epidemiology of fatty liver disease, some of the challenges in terms of making diagnoses, and where we are with non-invasive markers. I'm going to start by first establishing some clear definitions of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. And so NAFLD, or non-alcoholic fatty liver disease, it may be classified into NAFLD, which some people argue may or may not be a condition that exists. But the definition would be a patient that has more than 5% liver fat, but no evidence of liver injury, meaning there's no evidence of hepatocellular ballooning, there's no evidence of lobular inflammation, and there should not be significant increase in hepatic fibrosis. So the definition of NAFLD then is really just macrovesicular fat deposition in a patient with suspected fatty liver. NASH, on the other hand, is a condition where the liver's ability to handle the fat is overwhelmed, and so the liver has a variety of different things that it can do with fat. Liver, as you know, makes fat through de novo lipogenesis. The liver is a recipient of fat either through the diet or from the visceral adipose depot or other sites through the portal vein. And in fact, the liver may also package fat and export it in the form of lipoproteins. So when the liver is faced with an excess of fatty acids, the fate of those fatty acids is largely determined by the liver's ability to either store that in the form of triglycerides, which are inert and don't cause liver injury, through DCAT, which is an enzyme present in the liver. The liver can burn the fatty acids for energy via mitochondrial beta oxidation, or may package that fat in the form of lipoproteins and export them. When these processes are overwhelmed or not efficient, then you have a breakdown of the ability to handle the fatty acids, and now you have non-alcoholic steatohepatitis, where in addition to fat deposition, there's also variable degrees of lobular inflammation, and the hallmark feature of stress and injury to the hepatocytes, which is this descriptive term of hepatocellular ballooning or ballooning degeneration. And when we define, measure, and evaluate patients with NASH, we use the NAFLD activity score, or the NAS score, which assigns points to fat, inflammation, and ballooning, up to a total of 8 points, and we use this as a measure of response to treatment in clinical trials. Just to set the stage as to how serious of a problem this is, and the scope and burden of disease faced by the population, we estimate that in 2020, there were almost 80 million Americans with fatty liver disease. We estimate that 20% of that population may have NASH, which is the more serious form of this disease, which would be 16 million Americans. And we estimate that about 5% of patients with NASH will develop and progress to cirrhosis, which is a mind-boggling number of 800,000 people on an annual basis. So if you look at the US population in 2020, which was about 330 million people, NASH currently, 20% of NAFLD cases, expected to increase by 27% by 2030. Now, I've tried to classify NAFLD from NASH, and we have a number of different ways in which we can try to define this, but basically the definition of NASH and the description of NASH has historically been based on liver biopsy. And shown on the left is a liver biopsy sample that shows simple steatosis. So you have accumulation of fat, which is stored in the form of triglycerides, seen within the hepatocytes as those clear spaces. Whereas shown on the right is steatohepatitis, where you have not only steatosis, as you can clearly see, but also variable degrees of fibrosis determined by the blue staining color on the trichrome stain, and lobular inflammation, which are the little purple or blue dots, which essentially represent lymphocytes trafficking through the liver lobule in response to this injury. The long-standing effect of ongoing liver injury in NASH, of course, is the development of fibrosis. And as hepatologists, what we are particularly interested in are patients who have moderate to advanced fibrosis, because there are ample data showing that progression of disease to stage 2 or higher of fibrosis is what drives adverse liver outcomes. And this is an example of how we classify fibrosis stages. You can see stage 1, 2, 3, and 4, which would be established cirrhosis. And all of the research that we are doing now makes it exceedingly clear that in patients who have F3 or F4, stage 3 or stage 4 meaning cirrhosis, stage 3 meaning what we call bridging fibrosis, have dramatically increased rates of hepatocellular carcinoma, decompensated liver disease, and hard endpoints or outcomes that are liver-related outcomes. And these can be 30 to 50-fold elevated compared to the general population. Now, as I've already mentioned, the impact of fibrosis severity on mortality and liver-related outcomes in NAFLD and NASH has been well studied and well documented. And you can see in this graph, looking at the cumulative incidence of survival without liver transplantation, liver decompensation, incidence of hepatocellular carcinoma, major vascular events, or non-hepatic cancers are clearly driven by fibrosis stage. If you look at patients who have Child-Pugh class A with a CTP score of 5 compared to those who have a CTP score of 6, you can see there's a dramatic increase in liver decompensation, a dramatic reduction in survival without liver transplantation, significant increase in hepatocellular carcinoma incidence, but not as much of an effect on major vascular events or non-hepatic cancer. So although NAFLD and NASH are associated with increased risk of cardiovascular outcomes, once a patient has progressed to more advanced fibrosis, it's the liver outcomes that drive survival and end organ damage. So there is a pressing need to identify patients who are at risk for or who have already progressed to stage 2 or higher fibrosis in the setting of fatty liver disease so that we can try and intervene, and that's what pharmacotherapeutic approaches are aimed at. So what are the goals of NASH treatment? We want to improve the metabolic abnormalities if we can. We definitely want to reduce liver inflammation. We would like to prevent, arrest, or reverse liver fibrosis. And the AASLD recommends pharmacologic treatments aimed primarily at improving the liver disease should generally be limited to those with biopsy-proven NASH and fibrosis. This represents an important challenge for us who both do clinical trials and take care of patients, because patients are often unwilling to do liver biopsies. Sampling variability is a big issue in biopsies. Biopsies are associated with complications, and so we clearly need non-invasive tools to identify patients with NASH from those who have NAFL, to quantify liver fat in a meaningful way, because the level of liver fat may suggest the degree of inflammation. And before we can identify these patients, we have to be able to have the tools that are validated and approved. Our goal clearly is to prevent advanced liver disease, liver failure, liver cancer, and related outcomes, and ultimately improve systemic outcomes. So what treatments are currently available now in the clinic? I'll talk about that for a few minutes, and then we'll talk about the current therapeutic landscape with regard to clinical trials. So according to the AASLD clinical guidance, treatment of NASH with off-label therapies could be done with pioglitazone or vitamin E. And we showed in the PIVENS trial, which I'll describe on the next slide, as part of the NASH CRN, of which I'm one of the investigators, that both pioglitazone and vitamin E were effective in reversing NASH. Metformin is currently not recommended as a treatment for NASH in adults. It does improve liver enzymes and insulin resistance, but does not significantly improve liver histology or features on biopsy. There's a lot of enthusiasm about the GLP-1 receptor analogs, and clearly there's evidence that they are effective in NASH resolution, but we are still waiting to see data that they are effective in fibrosis reversal or prevention of progression to cirrhosis. So it is premature to consider GLP-1 receptor analogs to treat liver disease specifically in patients with NAFLD or NASH. Pioglitazone and vitamin E, on the other hand, in patients with biopsy-proven NASH, have been shown to improve liver histology, and in vitamin E, clearly in patients without type 2 diabetes, has been shown to be effective. We have some preliminary data suggesting that it might be effective even in patients with diabetes. But the risks and benefits of pioglitazone and vitamin E need to be discussed with each patient, especially if off-label use is being considered. So what is the PIVENS trial? This is the first landmark trial in the NASH therapeutic landscape. It was conducted by myself and the other investigators who are the principal investigators in the NASH Clinical Research Network, which is a long-standing NIH-funded network that we have been ongoing participants in for over 20 years. 247 patients were enrolled. They were randomized to either pioglitazone, vitamin E, or placebo for 96 weeks. And the key outcomes we examined were improved histologic features and fibrosis change. Vitamin E significantly improved histologic features of NASH as the primary outcome. We did not see benefit with pioglitazone, but I should point out the p-value for significance with pioglitazone in the study with both therapies was set at 0.025, not 0.05. We did not see a difference in fibrosis improvement, and we did not see any other significant changes, but we did see improved ALT, AST, and liver fat with both vitamin E and pioglitazone, as shown on the right. And you can see NASH resolution was actually seen more often in pioglitazone-treated patients compared to vitamin E, and both were superior to placebo. Now, when you look at the number needed to treat with vitamin E and pioglitazone, surprisingly low number. So in these 247 patients, the number needed to treat to achieve therapeutic benefit was 4.2 for vitamin E at 800 international units of D-alpha tocopherol per day, 6.9 for pioglitazone, and these were significantly superior compared to placebo. Now, what about pioglitazone in patients with diabetes or pre-diabetes? I've shown as an example the study by Dr. Ken Kusi, which is a double-blind, placebo-controlled, single-center study of 100 patients. Patients were identified with type 2 diabetes or pre-diabetes. Pioglitazone was used at a higher dose here than in PIVENS at 45 milligrams a day, compared to placebo for 18 months. And then open-label treatment was given for another 18 months. And the primary outcome at 18 months was a 2-point improvement in the NAS activity score in histologic categories without worsening of fibrosis. And pioglitazone significantly improved histologic features of NASH, and a greater percentage of patients achieved NASH resolution compared to placebo. And this improvement was maintained during the open-label extension. So we have drugs that are available now that we could consider using. Pioglitazone, of course, has some significant disadvantages. Fluid retention is one challenge. There may be other challenges, in particular weight gain, that make it not attractive to our NASH patients. So we need new therapies. But the proof of concept that we can reverse NASH and we can maintain this effect with continued therapy is well established. Now, when this study was presented at the European Liver Meeting, with liraglutide, there was a tremendous amount of excitement because you can see that 39% compared to 9% of patients with a relatively small study actually achieved NASH resolution. There was no significant effect on NAFLD activity score, no significant effect on fibrosis, but a significant improvement in ballooning and significant improvement in liver fat. And so we can see that the liver fat reduction is a very clear dominant feature of a GLP-1 analog. Now, semaglutide was studied in a much larger population and recently published in the New England Journal of Medicine. And you can see here that when you look at the odds ratio of NASH resolution, especially at 0.4 milligrams compared to placebo, it was 6.87. So 59% of patients resolved NASH with semaglutide at 0.4 milligrams a day. But when you look at fibrosis stage improvement, did not see the same effect. So from a liver standpoint, although the GLP-1 analogs very attractive with regard to NASH resolution, in terms of the endpoints that Dr. Malik and I are looking for as hepatologists, which is to reverse fibrosis and reduce progression to cirrhosis, at least semaglutide did not show that benefit. Now, when you look at changes with semaglutide in liver enzymes over time, clear improvement is observed in both ALT and AST, and it appears to be a dose-related change. So in summary, when you look at current treatments for NASH, here's what we can conclude. We want to assess the patient for presence of NASH or fibrosis. If they have steatosis but no evidence of significant fibrosis, we really want to be focusing on the metabolic syndrome, cardiovascular risk, and cancer prevention. If they have histologic evidence or evidence of significant fibrosis, then we would not only consider lifestyle modification, which we know is effective in NASH resolution and in fibrosis improvement, in the setting of fibrosis improvement requiring a 10% weight loss. NASH resolution can be achieved with a 7% weight loss. Obviously, we need to counsel patients to refrain from alcohol consumption. We might consider vitamin E in the natural form at 800 international units a day, especially if the patient does not have diabetes. We might consider pioglitazone, particularly in a patient with diabetes or who is insulin sensitive, if they do not have other risk factors for complications of pioglitazone. We need to keep in mind that statins for dyslipidemia should be considered, and some patients may benefit from bariatric surgery. But that's all we have as far as current therapies. Let me now talk about the new pharmacotherapies that are in development, and this is a very, very active state in terms of treatment landscape. So from a regulatory standpoint, the FDA has defined that liver histologic improvement endpoints, if identified properly, may be likely to predict clinical benefit. And that's the requirement for a drug to be approved through the Subpart H or surrogate endpoint accelerated pathway, which is to identify a surrogate endpoint that is reasonably likely to predict clinical benefit. And so what are the two things we aim for? Number one is NASH resolution, that is resolution of steatohepatitis, so the patient no longer has ballooning, inflammation, and they still may have fibrosis, but the NASH is gone. But to see that, we need to also document there is no progression of fibrosis, because we know as NASH progresses, the disease burns out, and patients may develop progressive fibrosis with less NASH. Similarly, if we're going to define fibrosis improvement, we require at least a one-stage improvement in fibrosis without worsening of steatohepatitis. So here are the endpoints that are commonly used in early phase 2 development for new therapeutic compounds in NASH. You could look at serum ALT level. For every 10-point reduction in ALT, you have an odds ratio of 1.3 for histologic improvement or resolution of NASH. For every 17-point improvement in ALT, that predicted response to therapy with obeticholic acid in the phase 2 Flint trial that we did as part of the NASH CRN. What are MRI-PDFF endpoints that might predict improvement? Greater than 5% absolute reduction or a greater than 30% relative reduction associate with histologic improvement. And these are based on somewhat limited data. So when you now step back and look at the landscape of NASH therapies, you can see it's an extraordinarily crowded space. To keep it simple, I've divided this into different categories of therapeutic agents. You could have drugs that block de novo lipogenesis, production of new fat in the liver. And for there, we have acetyl coenzyme CoA inhibitors, ACC inhibitors, such as firsicostat, and there are other drugs in development. There are PPARs that are actively being studied. Elafibranor did not succeed in reaching the primary endpoint in NASH resolution or fibrosis improvement and is not being further developed for NASH. Seladelpar is also not being developed for NASH, but saroglitazar, which is a PPAR alpha-gamma dual agonist, and lanifibranor are both in clinical trials at the moment. And lanifibranor is in a phase 3 trial. There's a lot of enthusiasm about thyroid hormone beta receptor agonists. So the liver has beta receptors for thyroid hormone, and there are drugs that bind to these receptors and make the liver more sensitive, if you will, to the thyroid hormone being produced in the liver. And resmetirom is a drug that a lot of you are familiar with, and there are other drugs from other sponsors that are currently in development. We've already talked about the GLP-1 analogs. The fibroblast growth factors, both 19 and 21, are currently also actively being studied. They have pleiotropic effects, both in terms of gut microbiome, both in terms of inflammatory signaling, and may have a keen effect or potent effect on fibrosis. And the FXR agonists, in some ways you might argue furthest in development due to obeticholic acid, having completed a phase 3 trial that read out in a positive manner, are also being studied with a number of FXR agonists currently in trials. And then there are others that are miscellaneous drugs that I won't get into. So let's talk about the drug so far that has shown a positive result in a phase 3 trial. And this is the REGENERATE study. And patients were randomized to either 10, 25 milligrams of obeticholic acid compared to placebo. And if you look at the primary outcome, which is a one-stage improvement in fibrosis without worsening of NASH, this was achieved in 23% of the patients in the 25 milligram group, about twice as many as the placebo group, and this result was statistically significant. However, obeticholic acid did not show a statistically significant improvement in NASH resolution without worsening of fibrosis. Interestingly, this study, which enrolled patients predominantly with stage 2 and 3 fibrosis, also included a subset of expanded cohort of stage 1 patients. And when you look at that population, you can see 21% versus 11% and 15% versus 8% in the 25 milligram group having not only fibrosis improvement, but also NASH resolution without worsening of fibrosis, respectively. So it's very close to achieve both of these things, both of these endpoints, and clearly effective in terms of fibrosis improvement. Now let's look at the phase 2 therapeutic landscape, where MRI-PDFF liver fat reduction has been used as the primary endpoint. And you can see shown at the top, FGF19 analogs, THR beta agonists, FXR agonists, FGF21, ACC, GLP-1, and THR beta, with a broad range of diseases ranging from NASH to early NAFLD. And you can see that the relative fat reduction with all these compounds is quite promising with some of these agents, with a relative fat reduction of as high as 58 and 59% with THR beta agonist drugs. So the future seems very promising at this point. And we need effective tools to quantify liver fat, and we need effective tools to be able to identify fibrosis without a biopsy, so that as these drugs are approved, we will need companion diagnostics that are widely available, point of care, and relatively inexpensive. And you can see here, shown at the bottom, the baseline fat fraction and the relative reduction of the fat fraction. And the baseline fat fractions in some cases were quite high, 20% and 18%, et cetera. Now here are the phase 2 data with resmetirom. This was 116 patients with NASH and fibrosis, stage 1 to 3. They were randomized to resmetirom or placebo for 36 weeks. And you can see relative reduction in hepatic fat of up to 50% in the higher doses of resmetirom. And you can see that the absolute reduction in liver fat can be 10 to 11%. And that's pretty impressive. If you have a patient that has a 20% liver fat reduction, you could see that a 10% reduction of liver fat may be enough to be clinically significant. So clearly, our ability to measure liver fat, our ability to measure markers of fibrosis in these phase 2 trials is going to determine which drugs go forward and how we can utilize them effectively. Now, the challenge with NASH resolution is that the definitions for NASH resolutions are quite variable. So some studies will say NASH resolution is defined by a patient having 0 for ballooning. And inflammation should be 0 or no more than 1. There should be no worsening of fibrosis stage, and the baseline fibrosis stage should be defined as stage 1 to 3. In other studies, NASH resolution is defined as absence of NASH based on a pathologist's gestalt, and no ballooning. So in the NASH CRN studies, historically, we have not measured NASH activity score numbers and required them to be 0 before we decide the patient has NASH resolution. It's the pathologist's overall impression. So depending on the study design, depending on how the pathologists are interpreting the changes, could have a very big effect on how you determine your treatment response. So in summary, if you look at the future of NASH therapeutics, it's a very active space. In 2021 to 2022, there was an Aramcol trial, which is now on hold. Resmetirom has met the primary outcome results in terms of lipid changes and is now in a phase 3 liver biopsy-driven study. Obeticholic acid has shown success with regard to fibrosis reduction, and there is anticipation that they may be trying to obtain FDA approval. And semaglutide, both as monotherapy as well as combination therapy with drugs that may be more antifibrotic, is actively being studied in clinical trials, as is lanifibranor, which is now in a phase 3 clinical trial. Thank you very much for your attention. Happy to answer any questions.
Thank you. Thank you to both our presenters, Dr. Malik and Dr. Kowdley. I have a question, and I'd be interested in both your perspectives, starting with Dr. Malik first, please. In your presentation about non-invasive point-of-care diagnostics, where do you see the optimal deployment entry point in the healthcare system before they get to an advanced hepatology stage to start measuring and intervening in liver fat?
Thank you, Francois. I think that's a great question. And I think it goes back to some of the slides that I was showing about the public health crisis, because this truly is a public health crisis, obesity and non-alcoholic fatty liver disease. And what we're seeing over the last 2 or 3 decades is that the interventions on this public health crisis have not reversed it. So the prevalence and the incidence is going to continue to go up. So then you have to substratify and say to yourself, well, how many of these patients do liver specialists actually see? We're a subspecialty of gastroenterology. We see patients predominantly in academic medical centres, and so we see a small population of these patients. So I think alluding to where your question's coming from, we need to have a multidisciplinary integrated approach where we can get point-of-care testing available with combinations of serum and imaging tests out into the community, where primary care physicians can use it, where endocrinologists can use it, where gastroenterologists can use it, and even if it involves integrative pathways with telemedicine, where, for example, a primary care physician could assess patients, put them into a risk profile group with high age, type 2 diabetes, obesity, plus or minus abnormal liver enzymes, hypertension, and then go on to a telemedicine once a month or every 2 weeks and discuss those patients about which patients they feel require further point-of-care imaging testing in the community. That would be one sort of strategy, but we certainly do need a strategy to get beyond the hepatologist to identify these patients early.
Thank you.
Yeah, no, I completely agree with that. I would answer the question in the following manner. How are these patients currently being identified? Typically, they're identified by primary care or endocrinology. And the endocrinology, because they have a high proportion of patients with type 2 diabetes. And usually what triggers a further question or possibility of NAFLD or fatty liver disease is either elevated liver enzymes or an echogenic liver on ultrasound. So I think doctors are pretty well trained to know that if they have elevated liver enzymes, they should do an ultrasound. Then we have this very non-specific result from the ultrasonographers who say, well, this patient has fatty liver. Well, of course, they don't have fatty liver. They may, but what they have is an echogenic liver. Where we need, I think, a great deal of work to be done is to train those primary care providers and maybe those endocrinologists to use these screening tools that Dr. Malik explained earlier to screen out the patients that are at low risk of advanced fibrosis and manage them with lifestyle modification. And then what we need is a secondary or tertiary referral process where there are point-of-care tools that can then take those patients who are suspected to have more serious liver disease and then have point-of-care testing available so that we can then be more specific in assessing liver fat, liver fibrosis, etc. And I suspect that will be a combination of non-invasive tools such as non-proprietary tests such as FIB4 or proprietary tests such as ELF, and combined with some sort of point-of-care test that can measure or estimate liver fat and liver fibrosis, then leading to further assessment with regard to liver biopsy or MR elastography or other more expensive, sophisticated tests where access is an issue. And it's really important to have these things available as point of care because as we all have experienced because of COVID, because of what's happened over the last 2 years, the healthcare system is really struggling just with the lack of trained available people to practice these, to utilize these technologies. So for example, in my practice, we have a hard time getting an MRI in a timely manner. And the reason we have a hard time getting an MRI in a timely manner is not because there are no slots available on the MRI machine, but because the physicians tell me that they don't have enough technicians who are trained or stay long enough in their positions. So we need to make these tools available to the practitioner at the bedside or in the ambulatory setting so that they can then utilize them more effectively.
Thank you very much. I think we have another question on therapeutics. Thank you, Dr. Kowdley and Dr. Malik.
Thanks so much to both speakers for your talks. It's very interesting. Going into the, it seems like just before the pandemic, there was a lot of excitement in the novel therapeutics, FXRs, PPAR agents, and now coming out as we attend these meetings in person again, starting this summer in Europe, seems to be a little bit more muted, the excitement, and there's a shift to lifestyle and GLP-1 receptor agonists. I was just wondering, from your perspective in your clinics, how do you view the changing assessment and guidance for patients?
Yeah. So, I think there are two reasons for that. I think three reasons. The first blanket reason is the wrench that the pandemic has thrown into everything: drug development, clinical trials, access to specialists, ongoing ability to see patients in a timely manner, et cetera. The second is, I think, the fact that there's some discouragement given several large trials that were phase 2B or phase 3 trials trying to use this surrogate endpoint pathway of liver biopsy have failed. And I think there's some skepticism and disappointment about that on the part of developers, on the part of sponsors, on the part of regulatory agencies, on the part of doctors, and on the part of researchers and patients. I think there was always an emphasis on lifestyle modification, and we have to remember that lifestyle modification is the bedrock of all of this, and we cannot exclude or forget about lifestyle modification. But the fact of the matter is that only 5% of patients over 5 years to 10 years will lose and maintain 10% of their body weight. So it is a huge challenge, and it's not because of a lack of willpower or patients' lack of interest in accomplishing this. It is a very complex process that once the body is used to a certain weight, it does everything possible to maintain that weight and will avoid trying to get to a lower weight. It's probably an evolutionary perspective, right? The second reason is that I think we've started to understand that our regulatory pathway for development of therapies in NASH, have been very dependent on this biopsy. And as we learn more and more about the limitations of liver biopsy with regard to sampling variability, biological variability, inter and intra-observer variability with regard to pathologists, there is confusion and even some level of skepticism or disappointment in whether or not these endpoints are going to be effective. So case in point is, for example, if you look at the FGF19 phase 2B trial. Now that trial did have a small number of patients, and if I had a wish, I would have wished for it to be a larger trial. But regardless, you could see all the non-invasive markers all moved in the same direction in a dose-dependent manner, in a positive way. But histology did not accompany those dose-dependent changes. So clearly we're making some impact with this therapy, but our primary outcome measure fails. So there, I think we need to kind of take a very 360-degree look at, is biopsy the right tool? And if biopsy is the right tool, are we measuring it the right way or looking at the right endpoints? I think those are the two things. There's no question, as I showed at the beginning of my talk, the unmet need hasn't reduced, and the need for pharmacotherapy is not going to disappear.
I wholeheartedly agree with everything Chris has said, and I would just add this on in terms of my clinic, my personal experience, because Chris has given a good, ubiquitous, global view on it. In my clinic, the things that I've found in the last decade that have been really, really helpful is, number one, a multidisciplinary approach to patient care, because it's a systemic disease, it's a multi-system disease, and obesity with the NAFLD, with the cardiovascular disease, it involves the integration of care with an endocrinologist, a nutritionist, a hepatologist, and part of that is the clinical trial specialist, so someone who comes in who's able to give our patients access to clinical trials. But in my opinion, the most effective person has been the bariatric surgeon. So the bariatric surgeon in my clinic has been the most effective person because, like Chris said, we get a lot of these patients who have gone down the track of trying diet and exercise. By the time we see them, they've been doing it for 15 years. And it's not a case of they're not trying. These patients are trying and want to lose weight. And it's looking at obesity like an addiction, like we do with alcohol and the other addictions. It is, these patients are trying, they're having a difficult time doing it, and it's obvious to me that when we are able to do an intervention that's effective therapeutically, like bariatric surgery, we see dramatic effects. We see reversal in obesity, we see reversal in NASH, I've seen reversal in fibrosis. So as part of that multidisciplinary integration and treatment, I would say at the moment bariatric surgery is my most effective treatment. And clinical trials, I'm waiting. I'm waiting with bated breath for a good NASH therapeutic to come out. But I think as well of what a lot of what Chris has emphasized is that it's those, and we did a talk here before COVID. We were having this discussion about 2 or 3 years ago, and I was outlining that one of the trip-ups, one of the things we have to be very careful in NASH clinical trials is it's not like hepatitis C, where you can just measure a viral load 12 weeks later and you can see the outcome. I was very concerned at that time about endpoints and how you measure endpoints. Are you using a biopsy? Are you using non-invasive markers? How are you measuring the effect of your agent? Because it's all great having hundreds of different drugs until you can test them and test the effect of them and see if they're effective. That's a whole different matter, and I think that's one of the challenges that we're seeing, which is an answer to some of the questions that you're asking.
Thank you both, Dr. Kowdley and Dr. Malik, for your time, your presentation, and for your accommodations with the unrehearsed fire drill. And I'm sure our listeners have enjoyed the sessions as much as we have, and thank you again both for your time, and we wish you a very strong conference and looking forward to seeing you there.
Thank you.